The introduction of Daratumumab and other monoclonal antibodies has significantly altered the landscape of multiple myeloma treatment. Daratumumab is a monoclonal antibody against CD38 that is currently being used across the entire spectrum of multiple myeloma disease phases. The Maia trial is a randomized phase 3 trial that looked at the addition of Daratumumab to Lenalidomide Dexamethasone as part of injection therapy in patients who are considered to be ineligible for autologous stem cell transplant. The initial analysis of the data showed that there was a significant improvement in the progression-free survival amongst patients who received Daratumumab Lenalidomide Dexamethasone compared to Lenalidomide Dexamethasone. The update that was presented at ASH 2020 represents 48 months of follow-up on this trial. The improvement in the progression-free survival remains consistent with the earlier reports. In addition, we also noted that all the different subgroups of patients appear to have benefited with the addition of Daratumumab in the context of progression-free survival. In particular, patients with high risk as well as patients with standard risk multiple myeloma appear to have derived similar degree of benefit compared with the standard Lenalidomide Dexamethasone control arm. The depth of response was also assessed, and what we found was that the minimal residual disease negativity was nearly threefold at about 30% compared to the 10% amongst patients receiving the Daratumumab Lendex compared to Lenalidomide Dexamethasone. In addition, we also saw that a higher proportion of patients had sustained minimal residual disease negativity, both at 6 months and 12 months with the use of Daratumumab in the combination. Finally, the data also is now mature enough to look at the PFS2, which is often considered to be a surrogate for the overall survival. The data clearly showed a significant improvement in the PFS2 with the addition of Daratumumab to Lenalidomide and Dexamethasone compared to Lendex. The results again confirms the superiority of this triplet compared to the doublet and makes a strong argument for using this triplet for initial therapy of patients with newly diagnosed myeloma who are not considered eligible for an autologous stem cell transplant.